There are actually two speakers there. We are actually going to do a shared presentation. I know it's a small confusion over there for you, but nevertheless, yeah.
So like GLP-1 and GAP and GLP-1.
It is
Go
a
ahead.
different experience for us as well. So I think before I give the stage to Dr. Adlyn, I think it is good to see all of you here. And I was also thinking it is perhaps a good time to have a medical conference at Chennai in the month of May, isn't it? Peak summer, nobody would like to venture out. On a lighter note, but having said that, I think congratulations to the able team of Dr. GVK sir. Congratulations to him and his able team to pull off such a wonderful, extravagant conference. It is so difficult to see so much of you in a gathering in today's world, right? So with this, I'm going to give Dr. Adlyn.
So I would like to thank Dr. GVK sir and the entire organizing team of 3D Con for having us here today, and also Novo Nordisk for having been a sponsor for this talk. So many times we talk about diabetes from a physician's perspective. Very rarely we talk about it from the patient's perspective, because what we are more concerned is about the numbers, the morbidity, the mortality. What patient is more concerned is about hypoglycemia, weight gain, and how well the quality of life with diabetes is going to be. So let's look through the lens of the patient. Now, we all know that type 2 diabetes is increasing steadily and steeply, and the world holds about 537 million of people with diabetes, and it's going to increase even further by up to 50% in the next couple of decades. And in India, we have no exception. We host already more than 100 million of people with diabetes. And more importantly, what you need to see here is the number of people living with pre-diabetes, which is again very, very high. And remember that all these patients are going to switch over to type 2 diabetes, adding on significantly to the burden, just like adding fuel to the fire. Now, regardless of the boundaries or the differences, be it a high populated state or an underpopulated state, diabetes has no partiality. It has no boundaries. What you see here is a very good political map of India, which we have all learned from the school days. But what you see in these colors is not just a random coloring or painting. The red color states show that the prevalence of type 2 diabetes is more than 10%. So that's really, really worrisome. And no state is an exception in regards to the number of people living with diabetes and pre-diabetes. Now, in the background of such a huge burden of the prevalence of diabetes, we also have to keep in mind that the burden of uncontrolled diabetes is also quite huge. So this is the data from the CARS trial, which is the cardiometabolic risk reduction trial from Southeast Asia. And this is from the Indian trial, the India Diabetes Care Index. Now, regardless of whether we have India or Southeast Asia, what you can see here is more than 3/4 of the population with type 2 diabetes do not achieve their target A1C of less than 7%. Now that's really worrisome, because with such a huge number of diabetes, such a huge number of uncontrolled diabetes, we are really going to have a huge difficulty and burden in managing these patients with type 2 diabetes and probably the complications of diabetes. Now, what as health care providers we really need to know, we will understand it from a case study by Dr. Arun.
Thank you, Adlyn. So as we saw the data, today, in the current era of diabetes management, we have a plethora of options, don't we? We have the SGLT2 inhibitors, we have the incretin-based therapies, and now many of these molecules are off patent as well, isn't it? Now still, largely as we saw from the previous data, majority of patients are still remain uncontrolled, right? Why is that? Firstly, there are two critical milestones in every patient's journey with diabetes. The first milestone is diagnosis itself, right? Invariably, there is a delay in diagnosis, which is not in our control. The other critical milestone is identifying OAD failure and initiating insulin on time, isn't it? Now, this is a very critical period in every patient's journey with diabetes, tantamounting to complications. I think over here, this is totally in our control. Diagnosis is a major challenge for a discussion for another day, but this is in our control, right? So here is where we would like to get the patient's blood sugar under control to preclude complications. So we're going to look at a case scenario and understand how we are going to approach. Here we have a 49-year-old gentleman who's a diabetic, hypertensive, and dyslipidemic, 2 drinks per week, not too bad. His blood pressure is also on the high side. So his HbA1c is hovering over 10%. Fasting is 200, postprandial is 220, stage 3 CKD, has atherosclerotic cardiovascular disk, and he's also been advised to adhere to a healthy diet. Now look at his treatment combination. He's on triple drug therapy, right? He's on SGLT2 inhibitor, good dose of metformin. He's also taking a good dose of sulfonylurea. Now, straightforward challenges, pretty much a straightforward scenario which we encounter in our clinical practice every day, isn't it? Now, today I had a patient who had HbA1c of over 12. Now, I was talking to him about the need of insulin. He was on multiple drug combination. So he said, give me 3 months time, doctor, I'll come back. Look at my blood sugar after 3 months. I'm going to exercise every day. Now think about this, already he's been losing weight, he's in a catabolic state. Exercise can even be counterproductive in such patients, right? So this is where I had to spend more time, then use my other assistants to kind of lure him into the conversation and finally convince him to take insulin, right? So that's the need of the hour in such patients. Although we have a plethora of choices, we're able to get the blood sugar under control in the first part of the journey of a type 2 diabetic patient. The cusp at which we require insulin, that's the time we should not have any delay. So I would like to bounce back this to Dr. Adlyn and ask her how she would approach such a patient.
I think these kind of patients are quite often encountered in our clinical practice. A middle-aged gentleman with more than trinity. You have obesity, diabetes, hypertension, dyslipidemia, microalbuminuria, and significant cardiovascular risk factors. So whenever we have these kind of risk factors, there are 2 things that come to our mind, especially putting the glycemic control again in the first point. So when this patient's A1C was 10.2%, so therefore we are looking at somewhere around 3% of HbA1c reduction. So when you have the OAD failure, regardless of, despite being on 4 milligrams of sulfonylurea, metformin, and SGLT2 inhibitors, the options are now limited. So we are looking at 2.5 to 3% reduction. The 2 things that come to our mind is 1 being a GLP-1 analog and the 2 being insulin. Now, how do we really go about? Again, there's a lot of things that can be discussed as to which over the other or which should be followed by the other. And what we really need to look at is to customize and really look at that individual who's sitting across the table. So though we have a lot of recommendations to suggest that basal insulin can be used initially, especially in these kind of patients where you really want to achieve an A1C control of more than 2% reduction, and especially when you have a patient with a predominant fasting hyperglycemia, a basal insulin would be much more preferable compared to a GLP-1 analog. GLP-1 analog in this case can also be considered when you are really looking at it from the cardiovascular risk reduction angle, but how much we'll be able to achieve a fasting plasma glucose control with the currently available GLP-1 analogs is still questionable, and especially when you are aiming for more than 3% A1C reduction, GLP-1 alone may not really do the job. So in that case, you can add a basal insulin and wait, and then probably add on a GLP-1 analog to look at the patient or address the patient as a whole, or probably add on a GLP-1 analog and then add on a basal insulin if the fasting target is not achieved. So there's no one right way of doing it. You can consider both and maybe one after the other as well. So having said that, I would like to ask Dr. Arun, how do you really go about initiating patients on basal insulin, and how it can really help us while managing patients with poor glycemic control?
Yeah, thank you, Adlyn. As Dr. Adlyn mentioned, I think GLP-1 receptor agonist has pleiotropic benefits, addresses multiple mechanisms contributing to hyperglycemia. However, it cannot be a blanket rule for all patients, right? The cost is indeed a deterrent. So the most pragmatic option in most cases is insulin. So we saw this patient has a A1C of over 10. So the first step is, again, identifying OAD failure. 3 OADs is already on. So adding another OAD is not going to help, right? So the first pragmatic move is to start insulin. So technically speaking, in such a patient, any insulin is all right, as long as the blood sugar is going to come down, right? Even a co-formulation is a good option, right? Even a pre-mixed insulin, if a patient is willing to take insulin, that's all matters at such a high HbA1c, right? But having said all that, usually the safest option or the gateway to insulin is always a basal insulin, right? That's how we initiate. So looking at the first generation basal analogs that we've been using for over a long time, now that we have the second generation basal insulin analogs, we are looking at some of the disadvantages of first generation basal analogs. Although we've been using it for a couple of decades, now we are looking at certain small, subtle disadvantages which the first generation basal analogs have, which is what? They are not truly once daily, perhaps it is not truly 24-hour acting. They have some peaks, which means there is a chance of glycemic variability. There could be also some nocturnal hypoglycemia, right? These are some of the disadvantages of the first generation basal insulin analogs, which are glargine, U100, and detamar, just for convenience sake. Now, what do we expect from a basal insulin analog? We know that the peptide acid sequential changes have been done to human insulin either to extend its mechanism of action or to reduce its action. Now, what we expect from a short-acting insulin analog is that it needs to be quite robust in bringing down the blood sugar. It needs to act quite fast. That's what we expect from a short-acting analog. But what we expect from a longer-acting analog is completely different. We don't want robust blood sugar reduction. We don't want fast reduction. We don't want any peaks. We, in fact, want it to have a very flat profile, long half-life, right? The expectations from short-acting and long-acting are quite different. So this is, as demonstrated in this illustration, we need a peakless profile. That is the hallmark of a true basal insulin analog. So comparing the first generation and the second generation, the first generation, there was a major shift when first generation analogs came in, right? We used to give NPH. There was a big shift or a jump to the first generation basal insulin analog because it was extremely convenient in initiating once daily. Titration was very easy. For even educating to the patients, it was easy. The risk of hypoglycemia was lower. Now, remember, friends, that's the kind of jump that we are witnessing from the first generation basal insulin analog to the second generation basal insulin analog. The newer analogs that we have, the risk of hypoglycemia, nocturnal hypoglycemia, is lower. The jump between the NPH and first generation, the similar kind of a jump we are seeing between the first generation and the second generation basal insulin analog. So a patient's gateway to insulin therapy, I would want to have the patient the best experience, right? I wouldn't want the patient to land up in hypoglycemia, because if patient lands up in hypoglycemia, the quality of life is affected, patient's impression on insulin is going to get affected, and hypoglycemia to the patient affects the entire family, not just the patient, right? So obviously, I would choose the best agent that is available today. Now, I'm going to pass the buck to Dr. Adlyn and make her answer the most difficult question. I can see some faces from both Sanofi and Novo Nordisk to answer the most difficult question. Which second generation basal analog do you think, Dr. Adlyn, has the edge?
I think, as you rightly pointed to, the problems that we faced with NPH insulin. Even I use insulin, even NPH insulin even now. I have never stopped using NPH insulin. But the difference of what we really expected from an insulin. It was gone are the days when we were really looking at the quantity of glucose reduction, where we wanted drugs that would reduce by 30 milligrams, 40 milligrams, and 50 milligrams. Now we have moved on to achieving the same glycemic efficacy with a better quality. So it's not just about quantity, but also about quality. So that really gives us the edge of not just managing diabetes, but also managing the person who's living with diabetes. So the first generation basal analog insulins did have a remarkable difference compared to the NPH insulin beyond glycemic control, with much less hypoglycemia and weight gain compared to NPH. Now, the second generation basal analog insulins that we have now are much, much better than the existing first generation basal analog insulin. Now, having said that, if you look at the glycemic efficacy per se, the difference may not be very significant, or you wouldn't see a graph which is separated by a huge gap. But what we really need to understand is, how do we get to that fasting plasma glucose? How do we get to that HbA1c? And what is the cost that the patient has to pay with regards to the number of hypoglycemic episodes and weight gain? So that's the difference between the first generation and the second generation basal analog insulin. Now, if you look at the comparison of these two basal analog second generation insulins, which is the degludec and glargine U300, this is the euglycemic clamp study from the type 1 diabetes patient, primarily to look at the GIR. You will see that they are much, much better when compared to NPH and the first generation. But between these two, there has been slight difference with degludec, almost very similar flat profile of GIR compared to glargine, which still has a slight peak, probably because of the glargine per se. But efficacy-wise, though it may remain the same, the variability within the day is slightly different between these two. And if you look at the inter-day variability, again, the inter-day variability also is slightly different between these two. Though the glargine has shown some peak, the risk of hypoglycemia is generally less with both these insulins, but even slightly better with the degludec insulin. Now, having said that, many times the benefits that we see with the RCT doesn't get translated into the real-world evidence data. Now, this is the confirmed study, which is a real-world evidence study, which showed that compared to comparing degludec and glargine U300, the hypoglycemic rates were much lesser with degludec compared to glargine U300, as well as the number of episodes of hypoglycemia. And this is in the insulin-naive patients. So whenever we do use a basal analog insulin, we need to remember that we need to adjust the dose of OADs also, especially when the patients are on sulfonylurea, which definitely puts these patients under a slightly higher risk in terms of hypoglycemia. Now, the dose time flexibility, both have their own flexibility regime. The degludec can be used once in 40 hours. Glargine U300 can be used plus or minus 3 hours, unlike the glargine U100. But we need to remember that the more flexibility that we offer to the patient, the more non-compliant or missing of doses can happen. So I personally do not really recommend patients to take one shot today and one shot day after tomorrow morning and all that. So looking at the potency, we know from the clinical data that the clinical efficacy in terms of fasting plasma glucose and HbA1c reduction is not much different. But when you look at it from the pharmacokinetics and pharmacodynamics angle, the area under the curve was much higher with degludec, possibly putting it forward for a highly potent insulin as a second-generation basal analog insulin without developing hypoglycemia. Now, this is the BRIGHT study, which primarily compared between degludec and glargine U300. And you will see that both were able to achieve the target A1C and target fasting plasma glucose. But the insulin dose requirement in a given day was much lesser with degludec insulin. And probably that has been attributed to the lesser risk of hypoglycemia and weight gain that we see with degludec insulin. Now, the RSSDA recommendation also suggests the use of second-generation basal analog insulin, especially when hypoglycemia and weight gain are the concerns. And basal analog first-generation insulins are still in use. Doesn't mean that this has completely replaced that, but we need to really keep in mind who are the patients who can actually benefit from the second-generation basal analog insulins, especially with regards to hypoglycemia and weight gain. So degludec has been approved to be used across all ages, across different scenarios, in pregnancy, in children more than 1 year of age, adults, elderly, and even in patients who are at a higher risk of developing hypoglycemia, like renal impairment and hepatic impairment. And therefore, you can use these second-generation basal analog insulins like degludec across all the spectrum of patients that you would come across in clinical practice. So last but not the least is always the cost. So whenever we talk about any molecule, are we really justified in making the patients pay for that quality of glucose control or the drugs that we really use? Now, given all the benefits of the second-generation basal analog insulin like degludec, you will already, which has been talked about by Dr. Arun, we also need to remember that cost also matters, and that also has to be kept in mind when we really also add on a quality in addition to the quantity of the glucose control. So let's get back to the patient. I think Dr. Arun will.
Sure, yeah, as Dr. Adlyn explained the advantages of second-generation basal insulin analogs. Now, we have a hypothetical case here where we are looking at initiating a second-generation basal insulin analog at a HbA1c which is over 10. Now, in some of my patients where the HbA1c threshold is lower, say about 8, 8.5, even in those patients, I kind of prefer second-generation insulin analogs. Reason being, since the threshold, the margin for error is quite less, the chances of hypoglycemia is in fact more in these patients, right? So at this point in time, when these second-generation insulin analogs are giving a whole light of experience in terms of the reduced hypoglycemia, I think there is no ambiguity. If the patient is able to afford, I don't think we should look even beyond the second-generation basal insulin analog. So the patient's A1C, the final details have not been given here, but however, at 3 months interval, the A1C is about 7.8. At about 6 months, the HbA1c is close to the target level of about 7. Now, the titration, etc., is not given, but we're going to look at another problem. At the end of 1 year, the patient's HbA1c jumps to almost 9. does this mean basal insulin failure, or would it mean that patient is perhaps non-adherent or non-compliant? We don't anticipate basal insulin failure to happen so early in his journey, right? Perhaps there could be a little bit of non-adherence and non-compliance. Dr. Adlyn, would you see such patients like this?
I think it will be a lie if we say that we never see patients with such a high HbA1c, those who were initially under good control. Now, we should remember that type 2 diabetes itself is a very progressive disease. We no more have that textbook recommendation values in every single patient during every single visit. There are patients who have ups and downs with their glucose control, but this is not a very uncommon situation that we come across in clinical practice. But I would like to be very specifically looking at the fasting and postprandial glucose, because that would help me to decide if the basal insulin titration alone would be sufficient to get the A1C under control, and or probably consider a co-formulation or a premix or a basal plus regime that would take care of the HbA1c as well. Now, having said that, we also need to remember the adherence part, which holds good for any chronic disease, especially with type 2 diabetes. Especially when you have put patients on insulin therapy, we need to make sure that the patients are taking it regularly and monitoring the glucose regularly also. So the injection is not just a burden for the patient in terms of physical pricking, but it's also a burden for the physicians, because we know that if the patient's blood sugar doesn't come down, the patient comes back and asks and saying, "Doctor, I've taken insulin, still my A1C is high and fasting is high." So daily administration of oral medication itself is difficult, and daily administration of insulin is going to be even more difficult, both for the patient as well as for the physician. So how do you go about managing these patients when it comes to non-adherence? Do you really have any other ways to manage them, and how do you counsel them?
Absolutely. As you mentioned, I think non-compliance is a huge challenge in chronic care disorders, isn't it? Now, that's why India perhaps is a pre-mixed market. We have the mixtures of the world ruling the roast, and it is always difficult to convince the patient of basal bolus therapy, although it mimics the physiology as close to normal, right? So challenges are always there. Now, how do we overcome this is probably with pre-mixed combinations, oral formulations. We have combination therapies, as well as at times when we start insulin, basal insulin, as we saw from the data earlier, when we have a flexibility of patients. Now, some of my patients say, "Doctor, I come home very late. I come at 11 o'clock. I tell them, no problem at all. This is an insulin which has a large window period of over 8 to 10 hours anytime. I mean, both the second generation analogs have a reasonably good amount of window period where you can initiate at any given time in the evening, right? So when you have such large window periods, it becomes convenient for the patient to take the insulin, and it doesn't coincide with the meal as well. So these are advantages, at least at basal insulin stage. But when we start intensifying, the problem always starts, right? Obviously, the problem starts, but that's another bridge to cross when we go there. But at least at the beginning, we would like to start off with a very flexible therapy. Now, I looked at the United States data. About 8% of the entire US healthcare budget, which is about $200 billion, are lost only because of non-adherence. Now, that's a huge challenge, right? It's very easy to prescribe a patient and then send them off. What happens is whether the patients are actually taking the medicines. Now we have a lot of smart gadgets, trackers. We don't take patients at face value anymore whether they're exercising. At least there are some tracking devices, isn't it? We also get deeper insights to patients' blood sugar glycemic variability. But whether the patient is actually taking medicine or not, until there's a clear log written, it's very difficult to track, right? That's some of the challenges that we have. However, I think we have to understand the pulse of the patient, recognizing where really is a shortcoming. Should family come into play, or today we can leverage technology, right? There is digital therapeutics. You can have alarms. You can have nudges, notifications. There are multiple options, but we need to understand the pulse of the patient, see where exactly is the problem, and then fix the problem. I think this is a real problem in hand to tackle in a patient with a chronic care disorder. Now, the other end of the spectrum, we have lipodystrophy. Of course, in patient whom I feel perhaps the adherence is there, still the blood sugar is not coming under control, then we obviously explore whether there could be any lipodystrophy. And how this can be overcome, I think this is going back to a medical school and not choosing the same site and changing the needles more often than not. And obviously educators, everybody comes into play for helping such patients. So going back to Dr. Adlyn, how do you approach such patients who are non-adherent?
I think as Dr. Arun said, reiterating on diabetes education, especially talking to the patient, checking their insulin, checking the site of administration, looking for insulin lumps, making sure they're monitoring the glucose and recording them. All these things really put some accountability on the patient as well as the physician, so we know that despite taking adequate amount of insulin that has been prescribed, the hyperglycemia has occurred, and that helps us to titrate the doses and probably look at other options better. So I think with all the chronic diseases, we need to definitely bring down the number of injections. So we start with basal insulin as a single dose, but then we know that diabetes behaves differently in different individuals, so we might have to step it up depending on the glucose control. So most important thing is, lesser the pricks, the more is going to be the adherence. That holds good for any disease for that matter, especially with type 2 diabetes and insulin therapy. And we should be fortunate enough to actually manage patients with type 2 diabetes in this era where we are looking at getting a once weekly insulin, we are looking at twin incretin, we are looking at triple agonist, so many other medications that can help patients to achieve their target glucose control, achieve their target weight, and also reduce their cardiovascular risk. And that's how we can make not just the quantity of glucose better, but also the quality of life of these patients living with type 2 diabetes better. So thank you very much and for your patient listening, and thank you for the opportunity.
Thank you. Before I conclude, thank you, chairpersons, and thank you to many of my teachers, seniors, and friends of the dais. Thank you very much, Dr. Vijayakumar sir, for this lovely opportunity, and thank you, as able team. Thank you, Novo Nordisk.
So thank you very much.